Good morning to all of you here in the auditorium and to all of you joining us online. Welcome to the third plenary of the 33rd Annual North American Cystic Fibrosis Conference. Ours is an amazing story, as we have heard from Marie Egan, Jane Davies, and Francis Collins. And tomorrow, as Dr. Collins reminded us, you will be going home to be with your patients and families. And so this plenary will focus on the exemplary care that you provide in partnership with individuals and families living with cystic fibrosis. First, we will recognize excellence in research and care. Over the past 2 days, we have been learning about scientific and medical advances in CF. And to keep these advances coming, it is important that we recruit and mentor the next generation of leaders in CF research and care. Part of this is by recognizing the up-and-coming generation of investigators who competed for the Junior Investigators Best Abstract in the Basic Science and Clinical Research Award. From a highly competitive field of over 250 abstracts, 20 semifinalists were selected, of which 2 winners were selected. I'd like to congratulate all the junior investigators who presented their work this year, and I am pleased to announce that the 2019 Junior Investigator Awards go to Melanie Sparrow from Caltech, and for clinical research, Vincent Giacalone from Emory University. Please, let's give everyone a round of applause. Next, I'm honored to present the Cystic Fibrosis Foundation's Mary M. Contos Care Champion Award. This award is presented to 2 multidisciplinary care team members who have made significant contributions in the clinical field of cystic fibrosis. Having reviewed the many highly qualified applications this year, 2 rose to the top. Both reflect the incredible tenure that is unique in our clinical community by serving people with cystic fibrosis and their family for over 25 years. Both are leaders on their respective teams, as well as nationally, representatives of their discipline and founding members of their mentoring programs. And both embody the focused commitment to improvement, a hallmark of CF care, by applying a rigor of quality improvement to continuously learn and to make things better. And who better to articulate the impact this year's Contos Awards have had than their patients? Our first recipient is described by a former patient she helped transition to adult care, who shares, "She has been a constant source of guidance and support, helping me come to terms with my diagnosis as an adolescent to my eventual transition to adulthood. With every roadblock CF put in my way, such as when anxiety and depression crept into my life, managing CF and life a seemingly impossible task, she always offered me a safe space to express my frustrations, reminding me that the roadblocks are just a detour in my journey, and that I may not get there on time, but I would get there. I am now thriving and am in nursing school, and I have her to thank for instilling in me the tools, the skills, and the confidence with tough, compassionate love to take control of my own health and to create my own path." A parent of a child with cystic fibrosis describes our second recipient by sharing, "We could not be more grateful for the impact she's had on our daughter's life. She puts my daughter's uncertainty and fears at ease the second she walks through the clinic doors. Managing CF is tough, and she empowers us and helps us navigate through the ever-changing emotions and struggles. To us, she is more than an amazing respiratory therapist and an incredible human being. She is truly our hero and lifesaver through this CF journey. And adding to this description is an adult with CF who says, I first met her when I was 12 years old, and she has put up with me through my teen years, which alone deserves an award. To know her is to love her. I'm so grateful for her tenacity, her dedication, and her passion. She's out in the community raising awareness and doing everything to make CF stand for Cure Found. I am proud to announce this year's Mary M. Contos Awards go to, and could you just hold your applause till I say both names, Barbara Jansma, CF nurse practitioner from the Children's Hospital of Philadelphia, and Kathleen Richards, registered respiratory therapist, Primary Children's CF Center, Salt Lake City, Utah. Let's give them a huge round of applause. Barb and Kathleen, all of us thank you for being champions of care for our community. Now I would like to introduce my colleague, Albert Farrow, Senior Director of Clinical Affairs at the Cystic Fibrosis Foundation, who will announce another award winner and introduce this morning's plenary.
Thank you, Cindy, and good morning. The Carolyn and C. Richard Mattingly Leadership in Mental Health Care Award is given by the Cystic Fibrosis Foundation each year to an individual in our community in recognition of their leadership and commitment to the mental health and well-being of people with cystic fibrosis. This award is a tribute to two amazing people and their inspirational devotion to the well-being of people with CF through emotional wellness. We are honored that Rich Mattingly is here with us this morning. I am excited to announce that this year's recipient is Professor Janice Abbott of the University of Central Lancashire in the United Kingdom. Professor Abbott was a lead researcher, Professor Abbott in her illustrious career has devoted more than 30 years to performing clinical research in CF and other chronic conditions, publishing over 48 empirical papers, multiple chapters and reviews. In addition, she's a teacher and research mentor, training the next generation of clinical psychologists interested in integrating mental health into complex chronic care. Professor Abbott was the lead researcher on the International Depression Anxiety Epidemiologic Study, TIDES, and her participation was integral to developing and publishing the International Mental Health Guidelines for CF. She's been a key leader implementing these guidelines across Europe. Please join me and Rich in welcoming Professor Abbott to the stage for this well-deserved award. Congratulations.
Thank you.
It's hard to believe it was 26 years ago when I first stepped foot in a CF clinic. And just like other specialty clinics I had rotated through, there was an attending physician to whom I would present. And in this case, that attending was none other than David Orenstein. Now, that would be special enough, and David's probably somewhere in the audience knitting and saying, darn right. And yet, what made the biggest impression to this then first-year fellow was that in this clinic, I would be partnering with Judy Fulton, our dietitian, Nancy Smizek, our social worker, Becky Mudich and Steve Walzak, our respiratory therapist, Liz Hardigan, our research nurse coordinator, Connie Richless, one of our nurses, and Louise Bauer, our clinic nurse coordinator, who had the unenviable task of trying to keep us all in line. And within this framework of the multidisciplinary approach, integrating the complementary expertise of people with CF and their families, the care model also includes collecting data, such as in the registry, defining current best practices, and disseminating them through guidelines and mentorship programs, and finding innovative ways to introduce new therapies to the clinic. A notable characteristic of the care model has been its ability to evolve in anticipation of the changing needs of people with CF. As we sit here at the dawn that promises brighter sunrises for so many in our community, we acknowledge that the needs of our community may in fact increase in diversity, and that the care model will have to be agile to respond to and rise to meeting these new challenges. We at the Foundation are resolute in our commitment to supporting care programs and the interdisciplinary teams as they rise, as you rise to meet these new challenges. To help us understand how we've evolved, attune ourselves to meet new challenges, and remind ourselves as to why we are well suited to meet them at a time when our future has never looked more promising, is Dr. Peter Mogayzel. I'm so excited to introduce Peter. First, I was so excited to see that he had left the Hopkins party last night and was actually here. But more so, I'm excited because he and I are kindred spirits in that we trained in the same generation, we finished our fellowships close together, we got to know each other very early in our careers. We have seen the evolution of the CF care model through similar lenses. Peter attended Brown University and received his MD and PhD degrees from Boston University and an MBA from Johns Hopkins. He completed his pediatric residency at the University of Washington in Seattle and finished pediatric pulmonary and pediatric critical care fellowships at Hopkins in 1998 before joining the faculty, where he's presently professor of pediatrics and division chief. He has served as the director of the Johns Hopkins CF Center since 2002. But not only is he a practicing clinician and center director, he has played and continues to play a prominent role in shaping the CF care model. Peter has served as chair of the Cystic Fibrosis Foundation Center Committee, as well as they did a little double take on me there. The chair of the Clinical Practice Guidelines for Pulmonary Therapies Committee and the Therapeutic Development Network Protocol Review Committee. We're actually looking hard to see if there isn't a committee Peter has not chaired so that we can volunteer him for it and sign him up. It's no wonder that Peter was the lead author on the history of the care model in that famous BMJ supplement. We are very fortunate to have him here today. As Peter comes up to the stage, let's watch a video that highlights the impact of our CF care model.
This isn't the story of a medical miracle or of a vanquished disease. This isn't the story of a past victory. This is the story of community, of patients, their families, and the researchers and clinical care teams who support them. This is a story about progress and transformation. The strength of this community over the last 50 years speaks for itself. Here's what it has made possible. With each success comes new challenges. With progress, fresh questions. More people with cystic fibrosis are living longer, healthier lives. More are working, and some are reaching milestones, such as college, marriage, and families of their own that would have been unimaginable just 30 years ago. As we enter this new era of therapeutics, we must continue to imagine new ways to meet challenges as we usher our care model into the future. For people with cystic fibrosis and their families, we count our success in lives. Together, let's write the next chapter of cystic fibrosis.
Wow, what an amazing journey we've taken. Our CF care model has been very successful. It's also very unique. So I'd like to begin by sharing a little bit of history about the evolution of the care model for you. Woe is the child that tastes salty for a kiss on his brow, for he's cursed and soon must die. This is a description of cystic fibrosis in the Middle Ages. Even back then, oh, hang on a second. Al is telling me I've gone a little bit back too far in time. Let me start over again. So why am I actually the guy up here talking to you? Maybe it's because I've been to NACFC. I've been around long enough that I've been here before in Nashville to NACFC. I was also wanted to say I was so inspired by the plenary yesterday. Francis was just amazing. And during the rehearsal yesterday, after I practiced a little bit, they said, you really can't sing. So you guys are okay, I'm not gonna be singing. But I did want to point out one thing about this picture. Over my left shoulder is the logo of the Human Genome Center. So during my fellowship, funded by the CF Foundation, I did my research at the NIH. So I was doubly inspired by the talk yesterday because it's Francis and working with Melissa Ashlock and her lab that inspired me to join the cystic fibrosis community. When I came to Hopkins, I planned to do pulmonary hypertension. So it's this community that allowed me to move forward and do what I do today. But the real reason I'm up here is because I've personally witnessed over the past 30 years a remarkable era of innovation. Innovation goes beyond the latest therapies that you've heard about in the past couple of days. We've been tested as a community to identify and meet challenges ever since Dorothy Anderson described the disease in the 1930s. She also coined the name cystic fibrosis. And as you saw in the video, we've been very successful. We've made extraordinary progress. But success can bring new questions, challenges, and opportunities. So I'm going to walk us now through some of the challenges we've faced and what we've done to take advantage of the opportunities. The ability of our unique care model to evolve defines us as a community. It allows us to continue to make progress that everyone with cystic fibrosis can feel. The challenge facing clinicians in the decades after Dorothy Anderson first described CF was to reimagine how this fatal disease could be treated effectively. Children with CF were not expected to survive to become adults or even teenagers. Children with CF were sick. This 5-month-old, obviously ill infant was not unusual in this era. The status quo was not acceptable to the families that created the CF Foundation or to the clinicians that took care of their children. They understood that to change the course of the disease, they had to innovate, to develop novel approaches to care. It's against this backdrop that Leroy Matthews and his colleagues in Cleveland proposed a new approach to care, one that focused on preventative care, including the clearance of mucus, prevention and treatment of infections, and enhancing nutritional outcomes. They hypothesized a way from just treating infections when they arose to actually preventing them could lead to better outcomes. This innovation was not only the treatments, but how the care was provided through a multidisciplinary team of experts that focused on various aspects of this multi-system disease. I'd encourage people to read this paper. It's really a remarkable landmark, and it is what our current care center model is based on. And here's the infant I showed you previously, and what she looked like 6 months later. She's an example of the success of this multidisciplinary approach in the early days. But now a new challenge emerged. How could high-quality care be provided to everyone with cystic fibrosis? To achieve this goal, the CF Foundation established the Center Committee in 1960. The foundation brought together experts to establish criteria that could be used to designate care centers. And these centers would provide specialized multidisciplinary care for all people with CF and support their families. Additionally, participation in research and training the next generation of caregivers became part of the core mission of care centers. An accreditation and funding mechanism was created by the foundation to sustain the care centers around the country. This slide shows you almost 290 care centers that care for the vast majority of people with cystic fibrosis in the United States. As a member of the Care Center Committee, I visited almost 50 centers, and I can attest that this system really works. However, success in expanding access to care created yet another challenge. To continue to provide high-quality care, we needed to develop and maintain the expertise of the team. The question was how to do this. An answer came from a simple suggestion by one of our own dietitians, Amanda Leonard. Wouldn't it be great if there was a training program for new team members so they could learn about CF and be oriented to our community? This was the nidus for the CF mentoring program. Originally starting with a program for dietitians, the mentoring programs have expanded to contain multiple disciplines and research coordinators. To date, 350 mentors have provided training, guidance, mentoring for more than 800 clinical team members, as well as research coordinators. The goal is to have a care center network that actually cares and supports one another. I know that everyone in this room wants to provide the best possible care. The challenge is for all of us how to synthesize the available information and apply it to our own practice. The CF Foundation has always thought to tap the expertise and talent in our community. From the outset, the foundation brought together experts to develop guidelines to establish optimal care for people with CF using the best knowledge that was available and expert opinion. The early guidelines shown here incorporated the concepts of preventative care, such as airway clearance and prophylactic antibiotic therapy, to support the new multidisciplinary care model. But guidelines are not static. The CF clinical guidelines evolve as new evidence and best practice emerge. There are multiple committees that update the guidelines on a regular basis, and the guidelines are available to the entire CF community, as well as including patients and families on cff.org. The challenges face us since the Middle Ages to understand the natural history of the disease and what therapies are effective. I want to point out, I did get the Middle Ages back into the talk again. This paper, authored by Dr. Dorshak, a giant in CF care who passed away earlier this year, was pioneering. He and his colleagues in Cleveland understood that data was needed to guide CF care. This study not only demonstrated that multidisciplinary care was effective, it also injected the concept that we needed information to inform care decisions. The CF Foundation seized on this opportunity to create the CF Registry. The realization that we need to understand the natural history of the disease, complications, and effectiveness was really the nidus of that registry. The CF Registry collected patient data initially on an annual basis, and now with every healthcare encounter, making it enviable as a comprehensive and accurate resource in our community. Registry data provides not only statistics about survival and complications on a population level, but it also provides information about individuals within care centers. And this data is publicly available on cff.org. And patient-level reports are also available thanks to innovative applications such as CF Smart Reports. Although difficult to measure, we know that CF lung disease starts early in life, even before there are clinical manifestations. Thanks to many investigators, including our Australian colleagues in the ARREST CF study, we found evidence that disease is early. The CF Patient Registry has also shown that the best outcomes occur with early interventions to optimize nutrition. Our challenge then is to be how to get treatments to patients as early as possible. Clinicians believe that if we could diagnose CF earlier, that we could treat earlier and prevent the disease manifestations and preserve lung function and nutritional status. This presented another opportunity, one to develop a best practice for diagnosing patients and then insert that algorithm into newborn screening throughout the world. This figure shows the number of people diagnosed with CF every year over the past 2 decades. The rising percentage of newborn screening is illustrated by the yellow line. Thanks to the efforts of Dr. Phil Farrell, the CF Foundation and Preston Campbell, and the CDC and many others, CF newborn screening has been propagated to every state in the United States. Phil has continued to engage all of us to enhance and optimize newborn screening programs. There are almost 90% of infants are currently seen within 30 days of birth. Not only in the United States, but in many countries around the world, our colleagues have worked to develop newborn screening programs. One example is illustrated here. This is the expansion of newborn screening in Europe since the year 2000. CF newborn screening is truly a worldwide effort, being available in Australia, Russia, North America, and several countries in Central and South America. As we move forward, the ability to prescribe highly effective modulators in infancy has the potential to change the course of the disease with many for cystic fibrosis. But examination of the registry data at a center level has also revealed something rather startling. There was significant variation in outcomes between centers. Our challenge then became how to reduce this variability in health outcomes. The CF community saw this as an opportunity to transform our care model to provide optimal individualized care for everyone with cystic fibrosis. The solution was to embed quality improvement in every CF care center, to address variations in outcomes and close the gap between the centers with the best outcomes and the rest of the centers. Collaboratives such as the Learning and Leadership Collaborative and the CF Learning Network have been created to propagate best practices throughout the care center network. Our success, though, relies not only on healthcare providers and administering advances in therapies. Our success depends on incorporating people with CF and their families into decision-making, on empowering them and advocates for their own care. We have to make them true partners with us. Together, all of us, people with CF, their families, physicians, and members of the multidisciplinary care team, and the CF Foundation have taken risks and developed a unique care model that has been remarkably successful. One tangible metric is shown here. Survival has improved dramatically over the years, not by the development of a single novel therapy, but by the consistent application of our unique approach to care. As Brent James put it, we in CF count our success in lives. Success can be measured another way. CF is no longer a pediatric disease, but one where there are more adults than children. However, this success presented a new challenge. How do we take care of the growing adult population? In my experience when I came to Hopkins 25 years ago is not uncommon. Pediatricians took care of both adults and children. We admitted adults up to age 40 to the adolescent ward. People over 40 went to the adult wards where physicians often were inexperienced at taking care of complicated, sick people with cystic fibrosis. In the 1990s, the CF Foundation recognized the changing demographics of the population and mandated this new approach to care. The pediatric population shown in blue on this slide was relatively stable, while the adult population in yellow was growing quickly. The status quo of everyone being taken care of by pediatricians was not going to be viable for the future. This realization led to the mandated creation of adult care programs in the year 2000 for those centers that had more than 50 adults. There are currently 118 adult programs and 43 affiliates caring for tens of thousands of adults with cystic fibrosis. Our experience at Johns Hopkins is similar to many programs. An interested adult pulmonologist, perhaps someone you know of, learned to care for people with CF in the pediatric clinic before embarking on the establishment of the adult program. Mike Boyle opened our adult program 20 years ago in 1999 with 75 patients. It's grown to 375 adults today. Mike's pictured here with Kathy Deinlein, who's still our adult program registry coordinator. Mike and many others worked to understand and overcome the challenges that face people when transitioning from pediatric to adult programs. One key finding of his work was that the ability of parents and families to meet adult providers before transfer greatly lowered their concerns about transition. Our current challenge is sustaining the multidisciplinary care model that we've worked so well in pediatrics in the adult world. CF care is fully integrated into pediatric training and care models. However, CF has a much lower profile in the adult care landscape. The complexity of care, the lack of trained adult providers has strained the sustainability of our traditional care model. To improve this situation, the obvious place to start was to develop and maintain adult expertise. This necessity led to the creation of PACE Awards to provide salary support and training to enhance the adult physician workforce. More recently, other CF grants have recognized the multi-organ aspects of cystic fibrosis and the need to bring subspecialists both into pediatric and adult care. The Envision grants for endocrinologists and the Digest Award for gastroenterologists have been created to respond to this challenge. And I know some awardees of these grants are in the audience today. As you've heard throughout this meeting, the molecular defect that caused CF has ushered in an exciting era of CF therapeutics development. It was almost unimaginable when the CF Foundation was founded. The idea that was to find drugs that not only treated symptoms but fixed the underlying defect. The foundation took up a challenge to develop new therapies with a rather unique, unorthodox approach. Venture philanthropy, as it's now known, was imagined by the foundation under the leadership of Bob Bell and a rather visionary board of directors who supported a big risk for a big gain. This novel approach garnered much attention at the time, as you can see from this article in Forbes. The vision has been brought to fruition by Preston Campbell and the current leadership of the foundation. I do want to mention, though, that I did get in on the act. That's me in the back. The only reason I actually got in the picture is all the senior people were on vacation when they came to take it. But I'm going to run with it, just so you know. So as we think about our successes and this new hopeful era brings, it does bring some challenges. Soon highly effective modulators will be available for the vast majority of people with cystic fibrosis. These drugs will change the disease for many people with CF, but not everyone is going to benefit equally. CFTR modulators are not going to reverse fixed disease. Some people may not tolerate them. Some people have mutations that don't respond to a modulator. As a pediatrician, I'm excited about the future of treating infants with CF immediately after diagnosis and maybe preventing all the symptoms of the disease. One vision of the future is in this projection of the pediatric population, developed using a model of highly effective modulators as being available for 90% of the population. Since CF is a genetic disease, approximately the same number of kids are going to be born every year, but over time, they're going to become healthier. While the pediatric populations are going to stay about the same size, the adult population is going to continue to grow. And adults will also become healthier over time. However, many adults will continue to have significant lung disease, nutritional issues, and complications of CF. As this figure shows over time, the proportion of adults with mild disease will continue to grow. However, there's still going to be a large segment of the population that will have significant manifestations of the disease into the foreseeable future. I've talked to you about some big challenges that our community has faced and overcome. I have conveyed to you the sense that our CF care model is dynamic. It's evolved to meet challenges and take advantage of opportunities. We've been very successful. We've developed a multidisciplinary care model to tackle a fatal disease. We developed a patient registry to inform care decisions and use quality improvement methodology to optimize care. And now as we embark on a new era when novel therapies may be available to even the youngest children, I've asked some colleagues to join me to give me their perspective on future challenges. But as they come up onto the stage, we first want to hear from members of the CF community about their concerns for the future.
We need to keep in mind that CF is not just a respiratory disease.
CF affects more than just the lungs.
Even sisters who share the same genes experience CF differently.
We need to keep in mind that many of us are living longer and are therefore wanting to start families.
Many of us now have little kids at home that we would love to see graduate.
We should keep in mind
that CF affects the whole family.
I was diagnosed 1 year ago at age 59, and I am concerned about the effects of medicines and treatments on my geriatric body.
We should keep in mind that for patients with antibiotic resistance, it often feels like we're racing against the research clock.
Not everyone has equitable access to treatment or to research opportunities.
Muchos pacientes no califican para la medicina nueva de triple combinación, la mayoría de los cuales son de minorías que además tienen otras barreras como el idioma.
I have a rare mutation, so where do I fit in with all these new modulators and treatments coming out? Because of right now, I feel invisible.
To improve CF care, we must find a prominent and permanent place for the voice of patients and families in all of our work.
We need to partner more, not only with our patients and our families, but also with community partners in order to impact the social determinants of health and quality of life.
Pediatrics and adult centers should partner together to engage our families early for the transition of care
and addressing mental health.
We should start thinking about topics related to women's health, including the impact of oral contraceptive therapy and pregnancy on CF.
Partnering with families from the time of diagnosis to promote both the emotional and physical well-being of the parents is critical.
To improve CF care, we should keep in mind
our patients need a strong, committed, caring team.
And now to discuss what we've heard and to give some thoughts on the future and future challenges, I'm joined by Sue Sullivan, who's the Adult Program Coordinator at Oregon Sciences and Health University, by Cindy Brown, who's the Adult Program Director at Indiana University, and by Terri Laguna, who's the Center Director at Lurie Children's Hospital in Chicago. You know, having heard from our community, I'm struck that we need to make our care model even more agile for the future, to really meet the different needs of the community. You know, Terri, as a pediatrician, what are your thoughts about the video and what you see for the future as challenges?
Yeah, so thank you, Peter. So one of the things I think that struck me the most, both about the video and also living in Chicago, which has an incredibly diverse CF population, is the importance of not forgetting that not everyone with CF is going to qualify for a CFTR modulator. So while this is truly an exciting time for the CF community, and we've heard a lot over the past few days about the clinical advances and the new modulators and all the excitement, there's still going to be about 10 to 20% of people with CF who will essentially be invisible, as per the woman in the video. And I think the approval of Trikafta has really accentuated this disparity, as I think patients, parents of children with CF are really becoming more aware of their genotype and whether they're going to qualify for Trikafta or something else, and exactly what that means for them if they don't qualify. The other piece I think is important is tied directly to that is people who don't qualify for Trikafta or another modulator, they tend to have rare mutations. And people who have rare mutations also tend to be from underrepresented minority groups. So African Americans, Hispanics, et cetera. And being from Chicago, where the patient population we take care of, about a third of them self-identify as Hispanic. So that disparity is just amplified. And when we looked at our population to see who did not qualify for Trikafta, that's about 20% of our patients who don't qualify for a modulator. And of that, over half are from an underrepresented minority group. So I just think now we have an opportunity to continue to send a message of hope and resilience to that specific invisible population, to let them know that we see you, we know that you're out there, and that we're not going to give up, and we're going to keep doing what we're doing until you have a cure as well. So, you know, the CF Foundation's Path to a Cure, this $500 million investment, is an important message. However, I also think that our patients, our parents, our families need to hear directly from us as pediatric and adult care teams that we are not going to give this up, that we're going to walk with them in their journey. So Cindy, I know that the adult CF population has become increasingly more complex. So what are your thoughts about challenges the adult CF population faces, and how do you want to start focusing on them?
Sure. As we see adults age, they are not only trying to manage a complex chronic disease, we also see these people trying to manage life, which obviously is very difficult for these patients. And a lot of times, there's a lot of outside factors that have influence that prevent them from really realizing the promise of these new therapies that include modulators, but not just modulators. We have patients who lose their insurance coverage, oftentimes for prolonged periods, for months and even years, maybe because they don't understand the complexities of their insurance marketplace, or they make just enough money to no longer qualify for Medicaid, but they can't afford plans on the marketplace. And sometimes insurance will abruptly change their specialty pharmacies, and their insurance coverage is interrupted, and they can't. They do, they really do. And now their health is compromised because their care is interrupted. We also have patients who, they have to travel very long distances to get to their centers. And for patients who make an hourly wage, this takes real money out of their pockets. And I know this is a problem for you in Oregon, Sue, with a lot of rural patients. We also have patients who have to choose between paying for food and paying for their prescriptions. And a lot of times this comes with a degree of embarrassment or sometimes fear. And we don't have a lot of solutions often to offer them in clinic, so they don't often bring it up with us. So as we think about the future, I think we have to think about how we can partner with our patients in a different way. But Peter's presentation gives me a lot of hope, because if you look back over the 50 years of this, we've seen a lot of innovation and a lot of impact, and the things that we do together as a community really does give us hope.
No, that's very true.
Yeah. So when I think about this, I think we can work together, and we have to be innovative and think about how we can evolve to meet this, whether it's partnering in new ways with community workers, or whether we leverage the technologies with telehealth to partner in different ways. So Sue, as a coordinator, how do you see this impacting your patients?
Well, I think you speak really well to the fact that we have to continue to treat the whole person. We have all of the science and the wonderful scientists working on treating the body, but we also have to have parallel efforts to constantly be reminded that people's mental health and well-being has to continue to be at the forefront. I had the opportunity to participate in one of the pilots for the Partnership for Sustaining Daily Care. And we got all of the materials in clinic, and I looked up, and there were only 3 questions, and it seemed very simple. And one of the questions to ask during your clinic exchange with a person coming in was, how are your spirits? Well, I have to tell you, it felt very awkward in those clinic visits, trying to fit that into your task list and what you want to accomplish. But over time, I realized, well, of course I have to ask them, how are your spirits? And now it's something that I bring just in every encounter, just to ask simply, how are you doing? And constantly trying to understand where they're at in their mental health and well-being, because as everyone in this room knows, this is a tough disease. And like you're saying, making sure that we're partnering with our patients to understand that it's not just about their physical well-being. I think it's important to recognize all of the work that the CF Foundation and all of the care centers have also done with understanding that mental health is such a priority. I sat in the audience and listened to a very important plenary a few years ago where it was, there is no health with mental health. And we certainly understand that the increase in anxiety and depression, not only with people with CF, but also their caregivers, is very relevant and has to continue to be studied. But with those challenges, with those discoveries, there's also been new challenges that have unfolded. As we've gotten mental health coordinators into our clinics, it's been hard for some institutions to continue to support the mental health coordinator grants. And we need to find unique opportunities to still find community partners to support mental health, and that challenge is there, and we can rise to that. I think it also presents another, great opportunity for strong advocacy work. You know, we have wonderful people at the foundation fighting, but we need to fight within our own institutions to make, you know, people who make decisions within our institutions prioritize mental health and well-being. And we have opportunities to get into our communities and really advocate on the behalf of patients and families at both our local, our state, and our federal level to make mental health not only affordable, but it has to be accessible. So Cindy, it's not easy taking care of adults, and you and I just you know, presented some challenges that they face, but they also, as they get older, they have more complex disease. So tell me more about what you're seeing in your clinics.
Sure. You know, I think what you brought up about mental health is very relevant and very important. You know, when we first started talking about mental health and how the importance of anxiety and depression and screening in our clinics, I think for many of us pulmonologists, it wasn't necessarily an easy thing for us to talk about. But it shows what, as a community working together and having the tools to talk about it makes a big difference. And that as a foundation, when we, in a community, when we come together, how we can really change the program. When I was really struck by one of the slides that Peter showed, showing the really large increase in the adult population over the coming years, that's a really big vision, and we need to be prepared to meet the needs of those patients. And a large number of them are going to have moderate to severe lung disease for a long time going forward. And that just shows how important our initiatives in advanced lung disease and lung transplant are. Jen, I know you're watching. She's a really great patient of mine who's had 2 lung transplants. And she messaged me this morning saying she's watching this machine on her Trilogy non-invasive ventilator because she just doesn't feel good. We're going to do better for you. There is a blessing and a curse about being the last plenary of the session. You know, it's kind of hard to follow Francis Collins.
It is. It's true.
But one of the things you see is some of the other sessions, and one of the things that really struck me was some of the differences between our outcomes in lung transplantation in the United States versus Canada. And it really emphasizes what we need to do in our network and how we need to continue to work together on advanced lung disease and lung transplantation. And all the efforts we have going on in basic science research and clinical outcomes and quality improvement are so important. But not just that. You know, when we look at this, we're going to have to continue to train adult pulmonologists, and we're going to have to continue to train our GI colleagues and endocrinologists. And there's going to be things we haven't envisioned yet. In the video, there was a patient talking about his geriatric body. We all have handfuls of patients who are in that age range at this time, but we need to be prepared to think about how are we going to take care of dozens of patients that are over the age of 65, and they may have complications we don't even understand. So maybe we're going to need to think about, do we need internal medicine providers and other types of providers in our clinic that we haven't even envisioned yet? It's a great problem to have.
It is.
And this is a good time to talk about it.
Yeah. So I just want to bring the conversation back to 2 points that you both have already made, both about the importance of mental health and also the importance of continuing to build that multidisciplinary team, and relate it to a situation that the pediatric care teams are familiar with, which is that initial visit of a new CF diagnosis right after a positive newborn screen. So oftentimes, we as a pediatric care team meet these families when the babies are 10 to 14 days old. Sometimes parents know about CF, sometimes they don't. But there's a lot of anxiety and stress in that room as parents get told that their new baby has a diagnosis of CF. And I can say on an aside that my conversations and the conversations of our care team with these parents have changed incredibly over the past 5 to 10 years. With now that we have new CFTR modulators, it's a different conversation. And it's more of a conversation of hope, of keeping your child as healthy as we can until that CFTR modulator is available for your age. However, I think the context of that conversation changes. We often know the genotype of these babies when we go into the room to talk with these parents. And so imagine, one, the stress of being told your baby has CF, but then two, being told that your baby's genotype does not qualify them for a medicine that 90% of the CF population has access to. And that's just going to add a whole nother level of stress and anxiety on top of a new CF diagnosis. So I think it's just important to think about how do we extend those mental health resources all the way down to that newborn period to support the parents, to support the families in a very vulnerable time where I don't think that we do the best job of doing that. I also think it emphasizes, again, just the importance of the creating that partnership and that trust amongst your care team with your patient and family, really. So regardless of whether your baby qualifies or your child qualifies for a modulator, we're working together. We're going to walk this journey together, and we're going to support you and keep your child healthy until that cure or until that new medicine is found for your baby. And that it just emphasizes the importance of us continuing to work together. So Sue, heading back to you as a nurse coordinator again, where do you see the opportunities for partnerships and how to work together better with our patients and families?
Yeah, well, I think this is honestly the easy part, and it's based on actually bad advice that I got. When I became a nurse, I went into critical care nursing, and I can remember my preceptor telling me, put a wall up. Make sure that you don't get too close to patients. I was taking care of the sickest patients in the hospital. Don't get too close to the patient. Don't get too close to the family. I feel very reassured sitting here 18 years later that that was horrible advice, and thankfully, and one of the things I'm most grateful for the CF people that I take care of and their families is that does not work. It doesn't work in any medicine, but it especially doesn't work in CF. You have to build relationships, and I'm always preaching, I have to humanize the face. I have to know them as people, and it's a two-way relationship. I find such joy that my patients ask me, how are your kids doing? Or it was very hard to transition. This summer I left Johns Hopkins and moved to Oregon, and one of the hardest parts was leaving the patients and families. These are people, and I know them as people, and that's what I think, that's the easy part. You show up and you care. So newer people in the audience, that's my biggest message when I teach nurses coming out of nursing school. I change that message that I heard, because in CF, just show up, build a relationship, get to know the person that you are taking care of. It's gonna make having those difficult conversations that you're talking of, Terri, much easier when you can make an awareness of where that patient is and that family and what makes them tick. So I feel, thanks, yeah, you guys live that every day. I'm so proud of the CF community in general and to be amongst here and representing the nurses out there. And I feel very proud that there are always people with CF and their families on every committee. In the CF Learning Network that I take part of, there's patient representatives and family representatives, and I love that, because we don't know all the answers, and these people live the disease. So I love that we bring them along on the journey. So I think it's helpful to understand that the CF Foundation supports efforts like the Partnership Enhancement Program. Cindy George will tell you I'm the first person to give her a plug for this program. And it's an 8-hour training, and I felt like Oprah, I'm getting my aha moment after aha moment, but it was real life skills to better, more effectively communicate with patients and their families to make conversations easier and run a more efficient clinic while you're doing it, learning basic communication skills. So I'm proud of the efforts. I'm proud to sit within this community. But the nice thing is that people with CF and their families, they don't expect us to know all of the answers. As long as we partner along with them along this journey, we are going to be in a good place.
I think you're absolutely right. Well, this has been a very insightful conversation, and I really appreciate your coming today and giving insights about the future. This just, I think, again, reinforces how we need to have an agile model moving forward. Before we end, I'd like to take the opportunity to introduce you to one more person with cystic fibrosis. So this is Lainey. You actually saw her before. She was in the picture with Bob Bell. You know, our paths crossed 25 years ago when I first came to Hopkins. She was diagnosed with cystic fibrosis from the first month I arrived at 5 months old. So she and I have kind of grown up together during this amazing era of innovation.
Hi guys, I'm Lainey. I don't know if Dr. Mogayzel prefaced this video by telling you guys I was his first patient at Hopkins in the CF clinic, PEDS clinic, but I was there. It makes me feel very cool. I'm 25 years old. I was born with CF, diagnosed at 5 months old. Growing up, I'll be the first to admit, I wasn't the best at adhering to all of that. When someone passes away though, you kind of think to yourself, well, I'm gonna do everything in my power to keep going and keep fighting.
You know, as you just heard, Lainey is going to keep fighting. She's my first patient, but we all know people like Lainey. They inspire us, they meet the challenges of living with CF every single day. You know, it's not only for them, but with them, that we need to keep innovating to make an impact on CF and the CF community so that people can really feel that change. We need to stay in this fight together as partners, as a community, until CF stands for Cure Found. I'd like to thank the panel, the foundation, and all of you for being part of this community. I hope you enjoy the rest of the conference.